So whether you're online or here in person, make sure you're logged into the Kahoot. We're getting started here in just a second. We will have the lab review in here. Nobody's in here after us, and I figure we don't want to have to go up to lab. Number one, it's dirty. Number two, it's stools instead of chairs. And number three, it's usually like really freezing cold in the lab. So we're going to try to stay in here. Nobody has a room scheduled, so hopefully nobody just shows up randomly and kicks us out. So we'll stay in here for the lab review. I don't think that anybody else is going to show up afterwards, but if we finish with our stuff in here today, then I'll go put a note on the door in between so that in case anybody else shows up. All right, make sure you're signed in. We're going to get going with me calling on you. Even if you're online today, you're still going to get called on today, and you still have to participate when I call on you. You can either type it in the chat or you can say it verbally over your microphone. I don't care what you do, but you do have to participate. So our first person today will be Cora. I'm not sure what your question is going to be yet. We'll have to see what we have, but just so that I'm going to try to keep you guys updated on who's going when, so that there's no like random surprise or suddenly calling you out. It'll be 13, chapter 13 first, and then we'll do 13, and we'll do the activity for 13, and then 14, and we'll do the activity for 14. These ones are a lot more straightforward than chapters like, 6 and 10, for example, which was pretty heavy. These ones are a little bit more, it's stuff that you've heard of, but now putting it into context more or less. And so shouldn't be as taxing as those other chapters, but it's okay. We'll work through them just the same. So we're going to go ahead and get started. Remember, you can always sign in using the number at the bottom of the screen. Or I put the number in chat also to join the Kahoot. All right, our first question. What is disease? On my camera. Okay. So disease, I knew everybody always picks the green one. Shame on you. So that's okay. That's okay. In this course, we mostly talk about disease that's caused by microbes. So Cora, your question is, can you name one disease that is not caused by a microbe? And even if you guys can probably think of any, if I recall you, are there any diseases that we've talked about, or not even that we talked about, any diseases, period, that are not caused by a microbe? If you're sitting there and you're racking your brain, that's how much you put yourself in a box. I didn't do that to you. You did. So Cora is going to think of a disease that is not caused by a microbe. And I challenge you guys to think of a disease that is not caused by a microbe. We'll chat so that I can see it whenever you're ready to answer. Disease. First, we have to understand what disease is. Disease is anytime you're feeling unwell, but more specifically, we think of disease as any deviation from health, perceived health. So what you normally feel like from your day-to-day basis, we know we're not in perfect health all the time. I'm not going to imagine that, but you're otherwise norm. You're otherwise day-to-day. Even if you're a little bit tired or whatever, that's not what we're talking about with disease. We're talking about deviation from perceived health there. And so there's a lot of different diseases actually out there that are not caused by microbes. So Cora, we're going to let you guess. So cancer is an example. That's one that a lot of people come up with. Shall we also talk about diabetes, heart disease, stroke? There's a lot of them. And so don't forget, disease is not contagious. Infectious disease is what's caused by microbes. And are all infectious diseases contagious? No. That's the other thing that chapter 13 kind of talks about too. What is it to be contagious? Yes, so yeah, we'll get into that a little bit with chapter 13. So yes, good job on that. So this is a good point to start looking at things that way, because chapter 14 is going to talk about epidemiology. And epidemiology also applies not just to infectious diseases, I hate to break it to you guys, but also non-infectious diseases and things like cancer and stuff like that. We still follow epidemiology for that stuff too. So chapters 13 and 14, kind of getting more towards disease, and we're going to focus on the infectious diseases. Adolfo, you'll be our next one on our next questions, just so you know that to get prepared. Okay, next question. Beautiful. We're getting there. All right, when resident microbes inhibit the establishment of infection by invading microbes, what's it called? So you got microbes that live in and on your body, and them being there prevent like bad guys. Yes. I'm sorry. Like looking at, there we go. Yeah, sorry about that. All right. So this is going to be called microbial antagonism. So this is that term that we need to be aware of for this chapter. So chapters 13 and 14 are definitely a little bit more like concept, I don't want to say more flashcard friendly is what I'm trying to say. A little bit more recall friendly. So definitely spend a bit more time with flashcards on these chapters. It's not as heavy and difficult as like chapter 6 and 8 and 10 were. But microbial antagonism is the term for that one. An antagonist in a book or anything like that, those are going to be people that are fighting against something. So in this case, the antagonism, the fact that our microbial population are fighting against that sort of stuff. So Adolfo, my question, I'm going to try to keep these kind of light. My question for you is, can you name one part of our body where microbes provide protection to us? Any part of the body. Let him cook, let him cook. It's his question. Yeah, let him cook. That's his question. Yep, I already see there's a chat. I'm not gonna pull it up. We're gonna let you cook with that. Any example of where microbes are providing us defense in the body? That's fair. Okay, so we'll say stomach, but not really as much the stomach. So I want to be very clear about that. Y'all going into healthcare. Is there a difference between the stomach and the intestines?
Yes.
Yes, so that's the difference, yes.
Would it be the GI tract? Is that what I'm trying
So you could say GI, so that's fair. So this is where we want to be a little bit more specific, especially moving forward, right? Especially as you guys are taking anatomy and physio, and then you're going into nursing school, being a little bit more specific with that stuff. So we could say the GI tract, that would be more general. The stomach actually has a little bit of biota. It's not free of the biota, but there's less because of the high acid content. Not many microbes can actually live that well in the stomach. So it actually is lower, but probably the best example that we have is our colons, like the large intestine. We have high population of microbes that live in your colon. In fact, the whole reason that you even have poop and farts and stuff like that is because of the microbes that live in our colon, helping break down our food into forms that we can use, as well as getting their own food from us. And they're taking up what I talk about. If you guys have watched the lecture, if you haven't, then I understand we've got the lab midterm coming up that you might be focusing on, but after the lab midterm, if you haven't watched the lectures, that's the time to watch the lectures. If you don't watch my lectures, really, like, you are missing out, I'm telling you, if you don't watch the lectures. I don't read my slides. I'll reiterate it again. So you're missing a lot if you aren't watching the lectures, because I'll also talk about things like, I'm not going to test you on this, but it was in the slides, and you might be wasting your time studying something in the slide that I'm not going to test you on. So FYI on that. Anyways, if you watch the lectures, you'll hear me talk a lot about the stadium seat theory. And I bring it up in class too, but I can't reiterate it enough. The stadium seat theory relates directly to microbial antagonism. Okay, so microbial antagonism is that idea that the microbes that form your normal biome are basically prohibiting bad guys from being able to take foothold for whatever reason. So think of your whole body. Every tissue in your body is an open seat in the stadium. Some of those seats are taken up by good guys so that bad guys can't sit down. And there are some parts of your body where that is more evident than in others. Your skin is pretty well harboring a lot of gram-positive guys that grow on your skin, live on your skin. No matter how much you wash or scrub for surgeries or anything like that, they'll eventually repopulate with microbiome. But your gut definitely has the heaviest amount. In fact, in 1 centimeter of your gut, 1 centimeter, if I cut like a slice of a centimeter out of your colon, there's more microbes in that 1 centimeter of your gut than there have ever been people on the entire planet in the history of people. In 1 centimeter, there's more microbes than have ever existed people ever, all of them combined. That's insane. And I'll bring that up again, put it in perspective. You think you're the one in control of your body? Interesting. You're harboring multiple centimeters. We're talking feet of colon that are filled with microbes, right? And so they're taking up the stadium seats, they're breaking down our food for us, and preventing bad guys from being able to take hold. This is where the issue comes from. Some bad guys, they don't care if the stadium seats are taken up. They can push the guys out of the way, or they can make toxins that'll kill the guys or whatever. So some microbes, some bad guys are already adapted to manage that. But generally speaking, for a large part of what just constitutes us being, human organisms, we have a lot of protection from our microbiome. And this isn't just talking about, when we talk about salmonella or something like that. We're again, don't put yourself in that box. How many microbes in our environment could have caused infection if you didn't have those stadium seats taken up? So when I have my salad, for example, sitting over here, which is going to be sitting here for the entire lecture period at room temperature, there could be microbes growing on it that if I didn't have microbes in my gut, those microbes could cause illness and stuff like that. Because I have microbes in my gut, now they're probably going to protect me and I won't get sick from my salad sitting here, whatever. So I'm not too worried about my salad, but that's the idea. All right, asthma would be a disease. So that's a good example of another disease that would not be infectious asthma. Not having an appendix affect the microbes in the GI tract since it houses our safe microbes. So we don't see that too much of an issue with that in modern society as much because we have a lot of different variety in our food sources and stuff like that to repopulate our gut. And I'll say this, not having an appendix isn't ever going to be an issue unless you have something come up where you depopulate your microbe population. So if we have guys sitting in the stadium seats and they are continuing to sit there, you're fine. But if we remove the guys in the stadium seats, then the appendix is there to have the backup guys to regrow and fill up the stadium seats. That's what we think the appendix is for. It has this backup plan. And if you don't have an appendix, then you're more likely to repopulate your biome just from your environment and things like that. We don't usually see too much of a negative effect on folks that are otherwise healthy being able to rebuild their microbiome when they lose their appendix. Now, if you were somebody that is, immunocompromised and we have to already prohibit you from having interaction with microbes in general, and if you didn't have your appendix, then repopulating your microbiome could be more difficult. So it just depends on that person's health, their environment, the types of foods that they eat and stuff like that. It's a good question. All right, so moving on. We got Adolfo. All right, next person will be Kristen. All right, yep, absolutely. Let's see. When do we first begin being colonized by our own microbiome? All right, whenever you are growing in the womb, then you are technically growing in a almost sterile, it's not quite sterile, but almost sterile environment within your own amniotic sac contained within there, whatever. But we now think that even in the womb itself, there is some microbiome that can help populate the baby as it's growing. Most of our initial exposure to microbiome and biota in the environment that can become part of us will be through the birth canal. Somebody that's born vaginally versus somebody that's born by a C-section, they're going to have different exposure to different microbes in those situations. Obviously, a C-section is set up to be as sterile as possible. And again, we're not crazy. We know that that's not perfect sterility there. But even then, it's relatively close to sterile until people start handling you and stuff like that. And that would be your first exposure to microbes that could potentially become part of your biome. As opposed to the birth canal, moving through the birth canal, there's quite a lot of microbes in the vagina, in the vaginal cavity. And so babies get exposed to that there. If you, for example, there's so much risk associated with getting exposed to the microbes there that if you have herpes, then we will actually, the law requires that you give birth by a cesarean C-section because if you have an active herpes infection, that's what I want to be clear about. If you have herpes and you're on the medication, you're not having an outbreak, you're fine to give birth vaginally. But if you're having an outbreak, we won't let the baby be born vaginally because we can't risk the baby being exposed to the herpes virus and it getting into its eyes and things like that. We're talking 50 to 80% mortality rate with that, by the way. It's not a joke. It's the law that you give birth by a C-section if you have an active herpes outbreak, because that baby is at a very high risk for dying because of herpes. So it's not a small thing. I'll be very clear about this. When we talk about herpes, when I'm talking about that type of herpes, I'm typically talking about HSV2. That's the more common genital herpes. HSV1 is what almost everybody in here has had. They talk about how we've all had herpes, we have had cold sores. It's usually HSV1 that causes the cold sores. They are both herpes simplex virus, and they can both be found on the genitals or in the oral area. Both of them can. But the one that's more common on the genitals is 2. The more common one for cold sores is 1. Both of them cause similar signs and symptoms associated with those diseases, though. So we'll talk more about that whenever we get into chapter 24. This chapter, we get into a little bit of discussion, like I'm talking about birth canals and vaginas and things like that, okay? And we're going to talk about epidemics. We're going to talk about outbreaks and things like that as we're going forward. But I want to be very clear, if you are squeamish about me talking about vaginas and penises and things like that, you don't belong in the nursing field, okay? And we're going to have pictures of that stuff too, because we're adults and we're learning about the diseases, and we're going to look at those pictures and things like that. Because I often get people be like, vagina, and I'm like, not saying it like that, but we get the feeling, right? And I'm like, no, vagina, like this is actually like we have our exposure to that stuff through that stuff, and we have to be thinking about it this way. And there's going to be some pictures, y'all, later on in the course that are going to make you very uncomfortable. And again, if that stuff makes you uncomfortable in my class, I'm giving you a little bit of a heads up now. Just it's coming, so just be aware of it. And again, you're going to be seeing this on real people, and you're going to have to interact with some situations in real people that it's going to make you be like, you're going to have to keep a straight face, and you're not going to know how to do it. And I wouldn't know how to do it in some of these cases. I had a student in my previous class yesterday who was working. She works in a hospital, and she said that they routinely get people into their hospital that are homeless, and they have frequent like STIs and things like that. And she had a stoma. Does anybody know what a stoma is? How do you want to tell me how she got chlamydia in her stoma? I'm sure you can. I'm sure you can imagine. Yes, exactly. Sidecar is what she says. You can imagine what that is. Okay, so that's the type of things you're going to see. She's already seen it. So be aware. You're going to see people. I've said it before, but I'm going to remind you again. If you ever do a cycle in an ER, you absolutely will see people with things up their butts. That you're going to be like, you put this up your butt, you put a water bottle up your butt, you put a beer bottle up your butt, you put a bong up your butt, you're going to see so many things up people's butts. People will do a lot to get pleasure out of things. I'm just saying, be prepared for, you will have to keep a straight face in these situations, okay? In case you haven't picked up on this, if you're somebody that likes to put things in your butt, I have no problem with this if you do this safely, okay? So I just want to say that I'm not judging the action, I'm judging the choice of the items, okay? To safely, it's okay. I just want to clarify, I'm not judging that. Okay. Yes, so we talk a lot about HIV in this class, right? So this is something that also, that's why I'm bringing it up. We talk a lot about HIV in this class, and a lot of people have a predisposition to think that HIV is more common in homosexual populations, homosexual male populations, and it's not true. The most common population is the heterosexual population. It's 90% of people with HIV are heterosexual, because the homosexual population knows that they should use protection generally. The heterosexual population thinks HIV is a gay disease, and it is not. The most common route of getting HIV, contracting HIV, is through anal sex. Right, so that's most likely. You can still get it through vaginal sex too. Anytime you're not using protection to have sex, HIV can get transmitted there through typically the micro tears. But we get the most micro tears through anal sex because it's just not meant for that type of action. So just FYI, populations that engage in anal sex are at higher risk. It doesn't matter whether you're homo or heterosexual. Where we actually find the most HIV tends to be in the lower income population areas, just because there's stigma and stuff associated with using protection. It's more, when I say stigma, I mean culturally, those populations have a tendency to decide that it's culturally in their groups, not as important that we use protection. It's more important to have the sensations and things like that. And it's the men making that decision for the settings, if we're being honest here, right? So anyway, stuff like that is stuff we need to be aware of and sensitive to as we're moving forward with our learning about these types of diseases. But anyways, let's move on. Next person I'm going to call on is Vic. I didn't even call on you, Kristen. I said I was going to. I'll call on Kristen next. So before we move on, this question. Okay. Can you tell me a benefit of breastfeeding?
Okay. Has all kinds of like vitamins and I mean like what your oh my god.
You're fine. I know
what that's called.
Colostrum. There it is. I know you're saying it. I see it in your brain. Okay, so yes, colostrum. Okay, so there's vitamins. So obvious one, the one that my student in my last class said, obvious one, what you're kind of getting at a little bit, but I know you're trying to get away from it some, is obviously nutrition. I mean, yes, obviously that's the point of breastfeeding. Yes, but that's, again, if I were to say outside of the nutrition and what you're getting at with the colostrum there. Colostrum has a lot of antibodies from the mom that gives protection to the baby. And when you're breastfeeding, that continues with the breast milk. Breast milk itself contains those antibodies that are protective for the baby as we continue through development. Babies do not have a developed immune system until at least 6 months of age, minimum. So for 6 months and longer, often, between 6 months to a year, babies can't even make their own immune response against something. So they're relying on the mother breast milk for that sort of protection to defend against microbes in their environment. If you don't breastfeed, you are missing out on that protection. So it's not just about the nutrition that you're missing out on. You're missing out on providing antibody protection to the baby. And there's one other thing that you're missing out on. Breast milk is not sterile. It's like milk. Milk, is it sterile? Is milk sterile? No. I mean, I hope you guys would know that, right? When it comes out of a cow or a person or a dog or a horse, any animal, it's not sterile. It's got microbes in it. And in human breast milk, the microbes that are in human breast milk are basically there because they break down human breast milk. Your body and a baby's body, a baby doesn't have bacteria in their gut. They have a sterile gut. So in order to populate their gut with microbes that can break down the foods they're going to see, breast milk often provides the first microbes to do that. And the microbes in breast milk break down breast milk. Babies cannot break down milk, formula, or anything at all. Their microbes do that for them. And so if you give a baby formula, they're missing out on antibodies, but they're also missing out on those microbes that help break down milk. And they won't get as many nutrients from their breast milk if you give them formula that doesn't have probiotics. So using formula with probiotics can get around this issue. But otherwise, I cannot emphasize enough, if you can, I know that there's plenty of instances why we can't breastfeed. But if you can't, then use formula that has probiotics in it. Otherwise, your baby is going to be colicky and fussy and have GI issues for a long time. And it's going to make your life harder too, not just the baby's. Babies, of course, harder too, but don't forget, you're affected by your baby's health too. So,
is that what causes colic? Is the lack of their biome?
That's part of what can cause colic. It could also be inappropriate ratio of microbes in the biome, stuff like that. So not having the biome or a different kind of biome than what would be ideal, that sort of stuff. And that can vary from baby to baby and from mother to baby. All those situations can cause that stuff to be different. And so, yeah, so you want microbes to be involved in your baby's food. You do, because they're going to help break down the food that the baby can't break down for themselves. So, yeah, I meant to say that. Also, if you supplement with formula, but breastfeed as well, the baby still gets the benefits. Exactly. It does not have to be all or nothing. That's a great point. So if you can breastfeed a little bit, even just for a little while, then the baby can still get some of those benefits. But if you are able, like, again, some people don't produce enough milk, or they don't have it available in their schedule for them to breastfeed. But if you can get some breastfeeding in there, then the baby can still get the benefits from that. Exactly. Good point, Tawny. I'm going to give points to Tawny. Tawny, I know you're sick, so if you need to go, I'm giving you points for participating because that was, I feel like, good discussion. Okay. Let's actually move on now. What is it called when infection comes from within your own body, not introduced from the outside? So Victoria, you'll be our next person. I hope you're online. Victoria. Yes, I know this is Victoria, Zoom user. It's Victoria, I'm pretty sure. Alrighty, so endogenous, endo is inside. That endogenous infections are coming from inside of the body, and give an easy question for Victoria online here. Victoria, what is it called when infections come from outside of the body? What's the term for that? I know you guys could probably guess it, but we're gonna let Victoria answer that one. I'll write it in the chat too, because I don't know if she was just kidding. Endogenous. So let's see. So we have a question for Victoria that she's cooking with. Barry, can you name an example of an infection that would have come from inside of the body, or a scenario where you could get an infection that came from your own body? Don't think too hard on it. Anytime that you have, well, I'll give you like a general scenario. So let's see if you can give me a specific example of it. Anytime that you have your own biome gets thrown off, then organisms that are from other parts of your body getting into parts where they don't belong.
What I was gonna say, and I don't think it's gonna be correct, but one of my wife was sick with necrotic infection. She got it from strep bacteria.
Okay, so that's a similar line of thinking. So the strep bacteria came from outside somewhere, right?
Right.
But then it moved to other parts of her body.
Right.
It's a similar line of thinking, but let's not get too, like, I know you guys know, this is the thing, is I know that you guys actually know this stuff, because when I talk about it, you recognize it. So yes, Brandon.
A UTI.
A UTI, perfect. Okay, so we'll give Brandon points for that one. All right, so UTI is an example. If you get a UTI, mostly ladies, okay, mostly ladies, men can get UTIs too. I want to be very clear about that. Typically, UTIs are basically bacteria, usually from your own poop hole, or your own anus, your own colon, getting into your urinary tract. In men, we see it more common in men who are having unprotected anal sex, or not completely protected from anal sex. So usually that would be from somebody else's, and that wouldn't be that way. Yes, an inner ear infection can be an example as well. Oftentimes in inner ear infections, when, let's say you have a cold, right? And you get inflammation in those eustachian tubes, which help drain the fluid out of like your ears, right? Then the inflammation there can actually cause us to not be able to drain that fluid anymore. And then microbes that naturally live in our sinuses and in our upper respiratory that live in the eustachian tubes as well will then overgrow inside of the fluid that got trapped inside of your ear. It's from the bacteria that were naturally there, overgrowing. C. diff. Y'all didn't think I was going to call out on that one, did you? C. diff is an endogenous infection, usually. Can you get C. diff from outside of your body getting introduced in? Of course you can. But many patients have C. diff naturally in their colon. If you have 1 or 2 stadium seats filled up by 1 or 2 microbes of C. diff, who cares? It's not going to make you sick having 1 or 2 C. diff. You take antibiotics, you clear out your GI tract with the antibiotics, you have all these open stadium seats. Now the C. diff that was left behind can overgrow, because C. diff makes endospores, and the endospores can survive antibiotics. And so it's really difficult to get rid of C. diff, and it'll overgrow. When that happens, antibiotics cleared out the biome and the survivors overgrow it, we call that super infection, which was another term for super infection.
But would staph be considered endogenous because it's on your skin?
So it'll be endogenous. Typically, yes, staph will be considered an endogenous infection. We have staph on our skin, and then you might get a cut or something and it gets into deeper tissues where it doesn't belong. Yes, right.
So like, I know it's technically a disease, but I want to clarify this. For like autoimmune stuff that
Mhm.
comes from genetics, like celiac,
Mhm.
does that also count under that?
So that's a disease that is caused by inside of your body, but not an infectious one. So we wouldn't, so that is celiac disease is an autoimmune disease, like you're saying. It is basically reacting against, issues in the GI items that are in the GI tract and then treating them as foreign when they're not. So that will be applying when we get to chapter 17, unit 3, we'll talk more about that. Yes, endogenous or exogenous, we're talking about the infection. So actually being caused by infectious microbes there. So it wouldn't technically apply to that particular term. Yes, Esther.
I'm so sorry.
No, you're good.
Is there someone trying to join? Or she's not sure how.
I entered it in the chat at the top of the chat. The PIN number for the Kahoot, you mean?
No, like, she wants to join the.
The Zoom, I sent the link out to the Zoom in an announcement, and it's the same Zoom link that we always use. So it's also at the left side of the bar, the Canvas course. That Zoom link, yes. All right, so, yes.
What was another term for super disease?
Super infection. So, so C. diff is an example of super infection. You usually actually, not most, not all, but many patients that have C. diff usually are already lived in their body. And now antibiotics killed everything off and now the C. diff is overgrowing, and that's called super infection. There's another example of super infection that you're actually probably, ladies at least, are more commonly associated with. Men probably are aware of it if they know ladies. And this is, yes. And so so I'll get back to Mariah's question here in a second, but yeast infections, right? So the yeast lives in your vaginal canal normally in small numbers, but then something throws off your bacterial biome. It could be sex, douching, anything that could affect the biome, including antibiotics for a UTI. So you take antibiotics for anything. UTI is just the most common one that we see this happening with. Or you have, sex and the hygiene and the activity and stuff like that can throw off your vaginal biome, or douching can throw off your vaginal biome. And so all this stuff can clear out stadium seeds. And now the yeast, fungi are not killed by antibiotics, are they? Antibiotics treat bacterial infection. So the fungi can overgrow then and lead to a vaginal yeast infection. That's also super infection when that happens. So super infection is whenever an endogenous microbe that's usually in small numbers is given an opportunity to overgrow. So that'll be super infection. So it's the same thing with C. diff, Mariah. So what'll happen is you typically either have C. diff already in your colon in small numbers, or you don't have it. And somebody in the hospital transmitted it to you, because it is usually a healthcare associated infection. You don't get C. diff outside of a hospital situation. I hate to break it to you. You don't. So people don't just wind up with C. diff. C. diff happens because of healthcare. And so it's either because you're taking antibiotics from healthcare that, opened up all those stadium seeds for C. diff to overgrow, or it's because you were taking antibiotics and then you came into contact, typically in healthcare setting, with somebody that has C. diff, or a nurse that got C. diff on their hands handling another patient that had C. diff, etc. You get the idea. So typically C. diff is a healthcare associated infection. And if you are in nursing, and you would probably agree with that statement, because we don't really see C. diff infections outside of the hospital settings. So it's a healthcare associated thing. And so there's that. Because the C. diff makes endospores, those endospores are very hardy. You wash your hands to mechanically remove them, and it should be effective. But if we're not 100% effective, if we're not singing happy birthday 3 times or whatever, for 30 seconds of hand washing, how many of you guys, you don't have to raise your hand, but think to yourself, how many of you guys, when you wash your hands, actually take the full 30 seconds to wash your hands? And every time you wash your hands, whether it's you go to the bathroom just at home, or when we're in the microbiology lab and you're trying to leave my lab, or you're going to be at a hospital now. And so you might be more mindful about it at the hospitals, but we should be mindful about it all the time. That mindful, 30 seconds. And even me, I'm gonna be honest, even in microbiology lab, I'm gonna soap up and wash and rinse, but I'm not gonna take the full 30 seconds to wash. But yes, that's 30 seconds just to wash your hands. We're talking about scrub prep for surgery. We're talking 2 minutes of active scrubbing in all of the crevices under your nails and everything for that minimum of 2 minutes. So stuff like that. So yes. So Gracie, I gave you points for your input on that as well. Okay, virulence factor. Next person is Morgan. Is Morgan in here? Okay, yes. I'm gonna have you give me an example of a virulence factor. So it's okay, I'm gonna give a little preface on what it is once we answer the question. Okay, anything that helps a microbe establish pathogenicity. So a more basic way of looking at this, any trait that any microbe could have that helps it cause an infection, anything. So we've actually talked about several in class. Can you give me one example? Adhesions. So that would be examples like that's more specific one might be Fimbriae on our bacteria that help adhere to surfaces. Another one that helps adhere to things would be the capsule. The capsule also helps evade phagocytes, our white blood cells, from eating them. So those are virulence factors. An example, another one that you guys already know about, flagella for motility. If we can move around, that helps us cause infection. That's a virulence factor. So we've actually talked about these already. So virulence factor, anything that helps it cause infection. Virulence has to deal with the degree to which it can cause infection. So virulence is the degree to which it can cause infection. Virulence and pathogenicity, basically the same thing, okay? Pathogenicity is talking about its ability to cause the disease. So similar idea there. All right, we got chat here. Enzymes, yes, enzymes could, exactly. So enzymes, their ability to break down certain things outside the host, we often would call those, in this chapter, they called them exoenzymes. So exotoxins, things that they secrete out of the body, out of their body, out of their cells, to break down things in the environment, which could be toxic to us. And a toxin is anything that causes damage to the host. So if it damages the host, we would consider it a toxin. So exotoxins could be exoenzymes that they're secreting out of their cells. So yes, enzymes would be a factor. So we'll call Mariah participated, and I saw earlier. Oh yeah, that was Mariah also. Okay, Mariah, you're good. All right, I'm trying to find it. Here you are. Good conversation, guys. All righty, we got Morgan. Sorry, bear with me. Oops. All right, let's move on. All right, select all that apply. Which of the following are signs? Signs. This requires that we know the difference between signs and symptoms. Did we ever get Victoria's answer? Let me see. No, we did not. We had Braley. I'm counting your participation, Braley. Is Caitlin in here today? Caitlin King might be online. Is Caitlin here? If Victoria, I don't know if Victoria joined later, but Victoria, I wrote you a question in the chat. So if you did join later, I did write you a question in the chat if you could answer that. All right. So signs and symptoms. So if we don't have Caitlin, Megan, can you tell me the difference between a sign and a symptom?
A sign is like a physical thing that can be observed by a health professional, and symptom is something the patient feels.
Excellent. So a sign is something that you could actually observe or even measure, but a symptom is going to be something that is reported by the patient. The patient says they're in pain. The patient says that they're having fatigue. The patient says that they're nauseous. You can't measure those things. They are subjective, right? The patient is reporting them. And so one of the things, here we go, yes. Right. Okay, it's up here. I'll copy and paste it again. We'll see. There you go, Victoria. All right. All right, so one of my other students was talking about signs and symptoms, and she was saying something about like how signs were, oh gosh, what was her example? I always think of a sign as being like, if we had like a stop sign, it's something tangible that you could actually hold up. Oh, she said sign language. Sign language is something you have to see in order to understand. I can't do sign language. I can do the alphabet, but that's it. So I'm sitting here moving my hand. I'm not trying to mock it, but like, I don't know sign language. So like A, B, C, like I can do those, okay? But sign language, you have to see it in order to understand it. But symptoms are reported. You can't see them, all right? So for this example, pain, can you see and measure pain? No.
Measure pain, right?
Can't how? How can you measure it? That doesn't rely on the patient's perception.
Okay.
So
yeah,
that's
'cause
the
patient's
difference.
basically telling you what
Mhm.
their pain level is.
Exactly, right. So that's the thing, but we have to get away from it. So we're relying on the patient to give us the information there. If we can't measure it, so we can think of signs as being things you can measure if that patient was unconscious. They can't tell you anything about themselves. You can measure their white blood cell count. You can palpate swollen lymph nodes. You can measure their fever with a thermometer, stuff like that. But nausea, pain, and exhaustion, these are examples that we can't really measure. Yes, perfect. Thank you. Well, you got Victoria. Okay, so would nausea be a symptom, but emesis would be a sign? Yes, so emesis is like nausea. We're actually producing something whenever we are having this, or we're gagging, like that patient is actively gagging, and you can usually tell whenever that's forced or whatever. So there is some, I will say this, there's some gray area in some of these areas, but I'm not going to put a gray area one on the test, right? Yes, Esther.
Like when people are in so much pain that they start like convulsing, does that?
Then the convulsing might be a sign, not like that's pain, is it? That's not actually, the pain is causing the convulsing is the sign, not the pain then. All right, so this is a thing where like we also have to take a step back because you guys, how many people here have actually worked in an ER? In an ER, so we have a couple. Okay, so ER is a little bit different, so I want to be specific about this. Okay, for the two of you that have been in the ER, how many each day that you worked in an ER? How many times have you seen somebody that is in pain, but isn't probably actually in pain? Drug seeking, every day, you will see it. Every day in the ER, you will have somebody coming in saying they are in pain, and they're at level 10 pain. And it'll be like this. Yeah, I'm at level 10 pain. They don't even hide it. I need Dilaudid. I'm at level 10 pain. And they'll be on their phones. They'll be chilling. Yeah, Sandy, I'm here at the ER. I'm in level 10 pain. I've been waiting 4 hours. And they're chatting, they're on chat, they're on whatever.
And they figure out how often
TikTok,
they can get it, and they
yeah.
put it on a timer.
And you can see this at the ER. You will see repeat patients coming in for their pain medication. When you guys tell me, because I know the answer to it. If a patient comes in asking for repeat pain medication treatment with Dilaudid or fentanyl or any of these other narcotics, right, that are addictive, are you allowed to say, hey, you have an addiction, you're not allowed to be here?
No.
Nope. You have to treat them for their pain.
But aren't you?
So it
allowed to
doesn't-
ask them if they're on.
You can, yes. So you can ask them about pain management, but it is against the law not to treat their pain. And if they're telling you-
But a lot of
Yes.
times if you sit
They're
there and
allergic
tell,
to
ask
it
them
too.
if they're on.
They'll tell you they're allergic to things. Yes, so they know their ways around it. So if they are drug seeking, then they will find their ways around it to get the drug that they're after. And I'll tell you this, if you're ever in, like, I'm not saying like you are in like level 10, like you are blacking out pain. I've been at level 10 pain where I blacked out before too. When I had my pancreatitis, I had level 10 blacked out from the pain. That was what caused me to black out. So that happens, that's real. But if that patient reports that they did that, you didn't see that happen, then how do you determine that it was there, right? So there's things that you can do. So one of my other students who was a paramedic and stuff like that, she was like, well, we look for like elevated blood pressure and pulse and things like that. Like if they were at level 10 pain recently, their pulse should be elevated. They should have high blood pressure. I didn't, because I have a nervous system issue. So when the paramedics came 5 minutes after I called 911, I woke up having blacked out from the pain. I called 911, they were there within 5 minutes. In less than 5 minutes, I think it was honestly like more like 2 or 3 minutes. And they show up and they're like, well, your blood pressure is 100/60 and your pulse. And they're looking at me the way that they do, right? Your blood pressure was 100/60 and your pulse was 65 beats per minute. It's like that, you know? And I'm like, yes. So I have a nervous system issue where when I'm under stress, my pulse doesn't react to it. So we can't be judging our patients on their pain level based on signs and symptoms and other things relating to pain. We can't. Sometimes when you see signs and symptoms, like you were saying, there's some patients convulse when they're in pain. Well, I mean, there's going to be times where you're going to be inclined to think this person is faking it. And there's going to be times when you're inclined to think that it's real. That's why we treat all of them as real. Even the ones that we know are drug seeking, because we can't tell the difference. So just adding that in as well. Can we measure pain itself? No. But can we disregard it? No. Right? So, you know, we can't disregard it. It's still a symptom, but we can't disregard it. Okay? Because pain is significant and it is impactful. So good discussion there. Yeah, I don't know why my heart does that way, but it's the real deal. I don't know why it does what it is. Tawny says, I work with sickle cell patients. Some of them have high pain, but are not as reactive as a general person. It's hard to see pain on our end because we may have one patient screaming, crying, and another patient sitting calmly, and they both say their patient is an 8. It is very subjective. And if you know a woman versus a man, and you've been to a tattoo shop, then you've seen the difference. Because if a woman, any tattoo artist will tell you that a woman will sit better than any man ever, because women have a higher pain tolerance, period.
I've had a sickle cell patient too, and them, I'm like, whatever your pain is, it's such pain.
Yes.
Because they have so much.
They have a ton of pain and they get used to it. And that's the sad thing. People who have chronic pain just get used to having a pain. And what they might rate as a 5 might be intolerable for somebody that it doesn't have chronic pain. You know what I mean? So it's very subjective. So we can't measure pain. It is not measurable. The best we can do is give them the chart that I know you're thinking of, the face chart. You guys know the one that's in the ER. It's like the face where it's smiling and then it gradually gets sadder and sadder and whatever. I typically think of level 10 pain as being something that causes physical issues. Level 10, you're passing out or you're having a convulsion or something. Like you have physical in like something that made you physically unable now to be able to handle the pain. That's level 10. And I don't consider anything where you're actually able to converse with somebody a level 10. Yes.
I don't have sickle cell, but I've had like period pain so bad that like I was shaking, throwing up. I had to be like sent home several times from school. They were like, this kid is not okay. Take her back home. I go home, I like fall asleep in the bathroom because I was in so much pain, right? Like I'm sweating, I'm crying, everything's wrong. And I was like, well, you can kind of see them.
Yes. So there are definitely some signs that come along with the pain that could help validate that, right? And so they're sweating. So for me, for example, when I had that pain where I passed out, I was sweating and I was like throwing up too, the sweating and the throwing up, but they weren't there to see that, right? And so when they came back and they're like, sure, you were sweating and throwing up, like that was how it basically comes out. So you experiencing those things is probably real, but then once that pain passes, if somebody else isn't there to observe it, do we discount it or not? And that's why we have to always be mindful of the pain somebody's experiencing, even if it was temporary, even if we didn't see it. Also, I will say that how many of us women, either ourselves or we know somebody that had period pain like that, and you go to a doctor and they're like, well, it's just your period, go home and you're fine. But it's probably a level of pain that maybe a man wouldn't be able to handle quite seriously. Just being honest here, okay? And that it's still real pain and it still affects your day-to-day life, but we're just expected, right? We're just expected to just tolerate it.
And the morphine is weaker.
Because of it. And you get it every month. Yes.
Side, is that something that can be observed?
Yes.
Like you can see it?
You can actually measure it somehow. So when we talk about like elevated white blood cell count, you can't like actually see it with your eyes, right? But you could take somebody's blood, send it to the lab, and you can see the value of the elevated white blood cell count. So,
Yeah, I was just trying to build down just a little bit, because like the palpate, you touch it, you can actually like, see someone is red or pale, that would
So,
be
yeah,
a sign.
I think of signs as just being verifiable. So yes, so seeing, that's fine if that works for you for remembering it, but I would say just verifiable is a more accurate way of saying it. You can verify that it is actually happening. That would be the better way of looking at it. So we have another question for this one, which is our symptoms. Which of these are symptoms is going to be this one. Symptoms. So signs, verifiable, you can see them. Symptoms, reported. We got Victoria. Esther's been participating. We got Esther. Next one will be Shelby. Is Shelby here? Yes, I was like, I know you're in here. I saw your face. Okay. I get disoriented. Okay, beautiful. So pain, again, just difficult to measure, right? Nausea, and especially how much nausea. We might get into the signs if we have enough nausea. If you have a significant heavy amount of nausea, but you're not quite vomiting, that amount of nausea can get to a point where you could observe it. But generally speaking, fatigue, pain, and nausea, and measuring those guys, it's just harder to do than palpating swollen lymph glands, or this is actually emesis is vomiting. So actually, trying to vomit something up, emesis. And then fever. And I don't know if you guys were told to say emesis or emesis. I was taught emesis, and then other people told me it was emesis. I don't care how you say it, as long as you know what it means. Say that. And like drugs, they call them antiemetics. So emesis, I mean, it makes sense. It's whatever. I was taught emesis, or whatever you like. All right. What is the term for lasting effects of an illness, even well after it has been cleared? The infection is gone, the pathogen is gone, but you're still having effects. There's two terms on here that we just saw, and then two terms on here that are commonly confused with one another. Beautiful, you guys got it. You didn't get tricked. So this is sequelae. So my question for you, Shelby, is can you give me an example of that? Where you have a lasting effect of a disease after you cleared the disease.
Like polio can cause everlasting.
Yes, that's the best one. I feel like it's the most obvious one. Polio, you can get polio, you can clear the virus, but you're still paralyzed. FDR was, right? So we see polio is the best example of it. It's the most obvious one. It's the one that I most commonly use on like exams and in talking lecture as well. But another one that we're also probably familiar with is long COVID, right? So we hear about long COVID a lot. And those people have cleared the COVID virus, but they still can't smell or taste, or still having significant fatigue and things like this, lasting effects of having had COVID.
Do you think that it being manufactured in a lab, that they took like a virus like HIV and the flu and like made it into this?
They probably made conscious edits to that virus that were based on knowledge about other viruses, but having to say like what, I don't know what the changes were that they made, but they were probably conscious. They were probably directed.
It's scary, like the long-term effect it's having on so many people.
Yeah, it is. I agree. So when we talk about like the heart disease associated with the vaccine, I want to be very clear that the heart disease associated with actual COVID is much more significant. And then again, we did our hand raising thing. How many people how many people in here had COVID? Almost all of us have had COVID. And in fact, the ones that think that they haven't probably have had it. A third of people that have had it don't know that they've had it. So could you potentially have heart disease pop up later from having had a COVID that you never had any signs or symptoms from? Yeah. So it's pretty crazy to think about, but yes, Raymond.
Would a less extreme, like say you had really bad chicken pox or some kind of like small, would those like skin scarring, would those be examples?
That would be examples,
Like
yes.
Okay.
Yes, that would count too. Yeah, so having chicken pox, so for example, I had the chicken pox, and I imagine that you had the chicken pox, and imagine I buried it. I mean, I'm not judging people's ages or anything, just saying. Some of us definitely had the chicken pox because again, the vaccine didn't exist when we were kids. And so I had the chicken pox, and you can't keep the kid from scratching the chicken pox. And so some of those chicken pox get infected and lead to scars. That's facts. And so if you have scars from chicken pox, and I have several all over my body, that's sequelae too. Yeah, technically. Lasting effects of that disease after I cleared it. All right, beautiful. We're doing good. We're doing all right. All right, what is the term for the phase of infection that involves a decrease of signs and symptoms? So Hannah, is Hannah here?
Increase.
Yes, decrease. Signs and symptoms going down. Let's see if I see Hannah. I don't see Hannah. I know Emma's here. We'll do Emma and we will do Anastasia, who's online. So we have two questions. I'll get Anastasia's typed in. Yes. Okay. So other Zoom user is Hannah, I'm assuming. Okay. We will do Hannah. All right, Hannah, your question. Okay. If the decrease of signs and symptoms is convalescence, I want Hannah to tell me what happens in the prodrome or the prodromal phase. And then I will ask Emma to tell me about the incubation phase, what's happening in the incubation phase. So and I'll draw a little thing for it too, to give you guys a little bit of reference on what I'm asking for. This was our like bacterial growth curve. You guys remember this? Stationary, whatever. And then basically like we have a period of time where from the moment that you get exposed to somebody that has COVID to the moment you start having signs and symptoms, there's days in there, right?
14.
Yeah, about 5 to 14 is what we say with COVID. And with any infection, that's the case. Most of the time, you don't like, if I have COVID and I walk up to Barry, does Barry immediately get signs and symptoms? No. So that phase, I'm already giving away the answer.
Like the incubation phase?
So that's the incubation phase, yeah. So that's what the question I was gonna ask Emma, but that's okay.
Sorry.
It's a hard one for me to get the words to ask the question. So that's okay. So the prodrome is a little bit easier. So yes, so exactly, beautiful. So this is Hannah. Hannah said the prodrome, which was a little bit easier to define, okay? So when you start having a bacteria get in, the period of time where it's like acclimating to your body before you're actually having signs or symptoms, that's what we call the incubation phase. And that's during the lag phase of the growth curve, okay? No signs or symptoms yet, we just got introduced. Then your very first signs and symptoms. First signs or symptoms. This is the prodrome. The prodrome or the prodromal phase. Either one is correct, okay? And this is when you first have your first signs or symptoms. When you wake up in the morning with that scratchy throat and you just feel it. That's the prodrome. Or you have a little bit of sneeziness or itchy throat, the prodrome. But when you are full blown and you're sick as a dog, we call this the acute phase or the infection phase. Max signs and symptoms, whatever the max is going to be for you, you're at your worst of it. That's that acute phase. And then once the illness starts getting cleared out by your immune system and we start having a decrease in signs and symptoms, that's the convalescence. Or the convalescent phase, same thing. We tracking that okay? So I'll ask you another question in a little bit, Emma, I promise.
I had invasion. Did I get that wrong? Did I copy that wrong?
Invasion, acute, infection, all those are accurate. Typically, I'm going to call it the acute phase, typically. But invasion isn't wrong. It's the same kind of. In case you guys can't tell, I'm probably going to ask about either incubation, prodrome, or convalescence, because there's a lot of different ways you can talk about that acute phase. Okay, I just feel like there's a lot of terms that they use for that one. So incubation, no signs or symptoms. It's that time in between infection and our prodrome. All right. The log phase is in here, log. So it's that period of when we first start the prodrome, in between the prodrome and the acute phase. That buildup of that would be the log phase, the exponential phase. It's a good question. So as you're getting worse with the illness, and then when you're at your worst, it's at its max. You're at the top of that log phase or you're in stationary phase. That makes sense? So I feel like it aligns pretty well with that. Okay, let's move on. I'll get another question for you, Emma, I promise. All righty, what is a fomite? I'll have you give me an example of a fomite. That's what I'll ask. So a little bit of discussion for that. And Anastasia, you'll be next. All right, so Emma, so if a fomite is a vehicle for transmission, and I'll be more specific, fomite is a non-living vehicle for transmission of an illness, okay? Can you give me an example or a scenario of that, Emma?
So like, this is like where we can get like influence type of thing.
Yes, so how, like, yes, perfect, exactly, yes, exactly that. So she said phones and doorknobs, pens, keyboards, they're all non-living. Is the doorknob infected? No, it's contaminated, right? And so the fact that it got contaminated from somebody that didn't wash their hands when they went poop, and then I touched the doorknob, and then I touched my eye or my mouth or something, and now I'm sick. The doorknob was a fomite. So it's a non-living vehicle for transmission. For Anastasia, I'm gonna ask, I know you're online. At least I thought I saw you online. Yes, okay. For Anastasia, I'm gonna ask you, what is a zoonotic infection? And I'll type it in the chat so you can see what I'm talking about. Zoonosis or zoonotic infection?
Terms interchangeable.
Yes.
It's a disease that is naturally transmitted through animals to human.
Perfect. Yes, exactly that. So for you guys, if you didn't hear her, she's saying it's going to be a disease or infection that's transmitted via animals to humans. So, so she did a good example of explaining that. Now, is Kennedy online? This is the hard part with as many people online as we have. I don't see Kennedy. Kennedy's not here either. Right? I'm not imagining this, okay? Because I had another student in one of my other classes who, like, she was sitting in the room and I kept thinking she was online. And I was like, why isn't she typing back? But she was actually talking to me and I thought she was a different student. Anyways, so Kenny's not here. So Lily, can you give me an example of a zoonotic infection? Or disease? So we'll let you cook with that one, Lily. Mhm. So there's plenty that we could probably think of, probably more than you realize, honestly. I'm being honest here. So there should be plenty. So we'll let her cook with that. There's a lot we can think of and we'll talk about them in a little bit. All right. Cool. One of the things that it talks about, I think it's going to be on the next slide, but I don't really remember. So I want to talk about it before I forget about it, is the other vectors of transmission. So if you are a non-living vector, then we would call you a fomite. Yes, exactly. Rabies. Rabies, I feel like, is the best, like biggest, most obvious example of a zoonotic infection. Something that's in animals that gets transmitted to people and generally isn't propagated by people, right? We don't see a lot of people to people rabies transmission, but we see animal to people. It's a very classic zoonotic infection. Another one that we don't often think about is actually like the flu. So a lot of our flu viruses came originally from animals, either from birds or swine. And so then they got adapted and then propagated in people after that because there is some people to people. But it came originally from animals. Anthrax is another one. It's actually maintained in livestock populations. It usually gets transmitted to people because it's in the livestock. Mad cow is another one. It's a little bit more obscure, but mad cow, it's one that was originated in the cows and got transmitted to the people. There's actually quite a lot. And the chapter has like a table of like quite a lot more of them that are like found in animals and then transmitted to people, but yes. So, okay, so non-living vectors, we call them fomites. See, TB, tuberculosis, we can have human to human transmission of tuberculosis, but we can also have animal to human transmission of tuberculosis because animals can become infected with it as well. So depending on how you're exposed, we might consider it zoonotic in origin. So that one just depends on exposure.
I used to have to get a tetanus shot every single year.
Oh, man.
Because of the cattle
Yeah.
and horses.
Yeah, they actually maintain that too. And yes. All right, so if we have living vectors, living organisms that can transmit disease to other organisms, you can either be a mechanical vector or a biological vector. Biological vectors are actually infected. examples might include birds with bird flu. Who was sitting at table 2 in the lab? You guys, I don't know if there's anybody in here, but yes, you guys had West Nile virus?
Yeah.
Yeah, birds, right? The birds maintained that in their population, and the mosquitoes transmitted it. Both the birds and the mosquitoes in that effect would be biological vectors. Often that's the case with mosquitoes. Mosquitoes are actually infected. Mosquitoes, definitely that's the case with malaria. All right, whereas mechanical vectors, they're literally just physically moving the illness around. Physically, we'll just say physically carrying pathogen. So they're not infected or anything like that. This best examples that we have of this. Anybody know what I'm getting at here? So this will be like, let's see if someone got it in the
You were
chat.
saying like the door handles. and stuff?
Roaches. So here you got roaches and flies. Beautiful. Thank you, Cora. Roaches and flies. The roaches are not infected. The flies are not infected, but they walk all over poo-poo and rotting things and whatever, and then walk onto your food and the environment that you eat your food off of. And then you get, transmit. They act like a fomite, but they're alive. So we consider those mechanical vectors. Okay? They're still alive, but they are not infected, mechanical. If they're actually infected, biological vector. The salad is a little bit different. So the salad, interesting.
Because like even like potato salad, they always say that during what is
I
it,
would say that the
Memorial
salads or the
Weekend.
potato salad in that effect might be more like the fomite. It's a different thing, I would say. A little bit different. It's still a vector though. It's a vector, but I wouldn't know that I would put it in any of these categories like hard. You know what I mean? It's more of a vague. So I won't ask you a question on the test about that, but thinking about that, it's still, they're not alive, right? So it would be more like a fomite, but they're actually growing the organism like media would. You know what I mean? So interesting. I don't know how I would categorize that. That's my answer. Sorry. All right, so we're gonna move on. We've still got, okay. We're done with this chapter. Any questions about anything else from chapter 13 before we move on? Chapter 14 will go a little quicker. We've got most of the people called on. My Charisse, Jessica, and Mikey, you guys are the ones I have left. So we'll get you in the next. All right, so our activity for chapter 13. Give an example of an opportunistic infection and one of a disease caused by a true pathogen. So my Charisse, can you tell me an example of an opportunistic infection? And I'll say, Jessica, can you tell me an example of a true pathogen? I'll give you guys a little bit of information to answer your questions. Opportunistic pathogens. It's like organisms that don't always cause disease, but can cause disease in certain circumstances. What'd you say? HIV? So no. So not that. So that one would be true pathogen. So I know Jessica's online, so I won't give it away too much, but that would be true pathogen. So in the case of opportunistic pathogens, so true pathogens, they cause disease. That's what they do. Opportunistic pathogens, they exist, but sometimes cause disease in certain circumstances.
So you're talking about like a tick bite?
No.
When the immune system
Yes.
weakens, that's when an opportunistic pathogen can take advantage of your body.
Yes. So, or if that organism, like we had endogenous infections, many of those are also opportunistic pathogens.
Kind of, so I remember something about like that, or Sarkovsky, some kind of a rare cancer that people with HIV, they compromised immune system, then they would get that.
Cholesteatosarcoma.
That's it, and then also like a toxoplasmicity or something that they.
Yeah, almost all of HIV. So I'll give you credit for this, my Charisse, because you're getting at the idea of it. Because having HIV makes you susceptible to opportunistic and pathogens, the opportunistic pathogens. So I know you're thinking about that when you're saying that, right? Because you're thinking like HIV makes you get all of these other illnesses, right? And so that's the AIDS part of HIV, right? So I'm gonna give you credit for it because that's what Brandon was getting at with his explanation of it. So that's fine, but opportunistic infections. So you have HIV, you're more likely to get opportunistic infections, weird ones like Kaposi's sarcoma and stuff like that. Kaposi's sarcoma is actually a cancer that your immune system keeps at bay. But if your immune system doesn't work, well, in the case with AIDS, it can't keep that cancer at bay. So your body actually keeps quite a lot of things, not just infection at bay with your immune system, including cancer. So your immune system can fight cancer. Some other examples like toxoplasmosis, which was, if you've seen Train Spotting, then you know.
That's what it's
Okay, yeah. Then you know the cat gave him, yeah. So, yeah, if you guys do watch Grey's Anatomy, Owen Hunt is in that movie. Kevin McKidd is his name. But anyways, he gets cats because he wants his girlfriend to come back to him. And his girlfriend's like, I don't want anything to do with you. Yeah, whatever. He has HIV. He got HIV from, intravenous drug use. And so he gets AIDS, and then he ends up getting sick from the cats, from the cat litter, and et cetera. He ends up having toxoplasmosis. Toxoplasmosis is technically an opportunistic infection in the sense that our normal healthy immune systems can fight it off just fine. But then if you have decreased immune function, you're more at risk for causing disease, which is true if you're pregnant and the fetus in the womb also can't fight off the disease well. And we also have, I think, about a third of toxoplasmosis infections lead to either stillbirth or abnormal birth defects. So it's quite a lot. Actually, it's not a small number if you get infected during pregnancy. So that might be an example. Toxoplasmosis itself, technically a true pathogen, but the presentation of the disease depends on your immune status. So it doesn't really exist like friendly environment. Okay, so an example that Barry gave us before. So Jessica's example of true pathogen was influenza. It's the flu. It causes the flu. That's what it does. How severe your flu is depends on your body, right? So the example that I think Barry, I think it was you talked about UTIs earlier. I think you brought up, or was it you? Somebody, one of you gentlemen brought up about UTIs, right? And it being an endogenous infection. That E. coli that causes your UTI is normal in your gut. It does work for your gut. It's a happy, good, friendly microbial antagonism. It takes up a stadium seat, but it doesn't belong in your urinary tract. So when it gets in there, endogenous infection, that's an opportunistic pathogen. Okay, there's a lot of different kinds of E. coli, a lot of different strains, and they can lead to a lot of different types of diseases. We'll learn about them in chapter 23, all the different E. colis, because you're probably thinking like E. coli is bad. They talk about it on the news. There's certain strains of E. coli that are true pathogens and certain strains of E. coli that are endogenous opportunistic pathogens. If we talk about how some people get mold fungus growing in their sinuses from, mold allergies and whatever, that's an opportunistic pathogen. Now, mold doesn't always cause illness, does it? It's opportunistic pathogen. Oftentimes when we talk about endogenous infections, a lot of those are opportunistic pathogens. They're taking that opportunity to cause the illness, but outside of that opportunity, do they always cause illness? No. So flu, HIV itself would be true pathogen, and then the infections that come with having AIDS would be opportunistic pathogens. Flu is true pathogen, tuberculosis, true pathogen, COVID, true pathogen. That makes sense? They always cause disease, those things. They're not ever going to be like chilling. We good? All right, give an example of a virulence factor for any, so we got credit for them. Okay, good. A virulence factor for any pathogen, we talked about that earlier. We talked about the capsules, the attachment adhesion was what we said, and that sort of stuff. A pathogen that causes malaria is protozoa. The pathogen that causes HIV is a virus. The pathogen that causes tuberculosis is gram-positive. The pathogen that causes cholera is gram-negative bacteria. Which of these pathogens would have endotoxin? Anybody know? So it's something that we, yes, Kristen. No. Gram-negative, why? Yes, so we're getting there, right? So remember, this is from unit 1, and this is where it is in chapter 13 as well. I'm not just asking a question from unit 1. It's also revisited in chapter 13, okay? So we revisit this idea of the toxins, the endotoxins, the exotoxins, the exoenzymes, all talked about in chapter 13. Endotoxin is one thing and one thing only, LPS in the gram-negative outer membrane, period. It is not ever anything else. So if you ever hear the term endotoxin, it's talking about LPS in the gram-negative outer membrane. So the only one here that has endotoxin is cholera, or gram-negative bacteria. That's
LPS or?
LPS, lipopolysaccharide. I can say lipopolysaccharide if that is clearer, but I feel like that's a mouthful. Lipopolysaccharide.
They have an LPS coral. Aquarium tanks.
Yeah, I don't know anything about that. Sorry.
So maybe
I believe you. Yes, so lipopolysaccharide here, lipopolysaccharide. And it is a molecule on the outer membrane of gram-negative bacteria. So this is where I say, I'm not going to necessarily test you on unit 1 in your unit 2 exam, but if you don't remember how unit 1 applies to the stuff, and it is talked about in chapter 13 as well, then you can't let go of unit 1, right? We're constantly using that information, okay, and building off of it. So number 4, explain why nausea is considered a symptom while vomiting is considered a sign. I'm actually going to let Mikey, this is your turn. We talked about this previously. Why is nausea a symptom and vomiting a sign?
Nausea is symptom of the body weight or stimulation brain while vomiting is a sign.
You can measure it and you can see it. Yes. So vomiting, like she's saying nausea, it's something that's going on in the body that the patient is experiencing. It's not something that we can measure, but the vomiting, you can actually see it as an outside person and measure it. So exactly right. Okay. And then syndrome. So this was another one that I forgot to go over. Does anybody know what a syndrome is? We've called on everybody. Anybody want to volunteer? Yes. Perfect. So you're Morgan, right? Okay. Still trying to, I'm not good at learning people's names, so you got to forgive me on these. Okay. So really quick, syndrome. A syndrome is a disease defined by the signs and symptoms, not the cause. All right, so if you are coughing and you have a fever and you've got maybe a little bit of a runny nose and a sore throat and you've got swollen lymph nodes, do you say that is a specific kind of disease? Probably not. You probably want to test the patient for COVID or flu or RSV and then say they have COVID or they have flu or they have RSV. Those diseases are defined by what causes them, right? Tuberculosis is caused by Mycobacterium tuberculosis. Flu is caused by influenza virus. COVID is caused by that SARS-CoV-2 virus. So those are diseases defined by what causes them. However, if you go to a hospital and you've got stiff neck, headache, fever, so what did you say? Meningitis. Okay, so you got stiff neck, headache, and a fever. They're going to be like, and photophobia, which is light sensitivity. You got all those things going on, those 4 things. We're going to call it meningitis. We don't care what causes it yet. First thing is, it's meningitis. If you have inflammation of the meninges, which causes photophobia, headache, stiff neck, and a fever, then you have meningitis. Meningitis can be caused by many different kinds of bacteria, a few different kinds of fungi, and a whole ton of different viruses. But it's still meningitis, even though it can be caused by all these different things. Make sense? Another one that's more obvious, really, I feel like it's more obvious. It's one that you actually live with on a regular basis, is the cold, the common cold. If you have a cold, do the doctors really care what caused your cold? Do you guys have any idea how many viruses can cause a cold? Over 200 different viruses can cause a common cold. So that's defined by signs and symptoms. You may not have a fever at all with a cold, or it might be very low grade, below 100, or even below 101, right? Maybe a low grade fever, but you've got a runny nose, even maybe a stuffy nose, runny or stuffy, one or the other. You've got a little bit of a sore throat and maybe a mild cough or something like that. It's not the flu, it's not COVID, it's not RSV, then we might say it's the common cold. But 200 different viruses can cause that, including adenoviruses, different coronaviruses, not SARS ones, but other coronaviruses, and all sorts of different things can cause the cold, right? Rhinoviruses. There's a ton. All right, makes sense about syndrome. So when we talk about AIDS, acquired immunodeficiency syndrome, It's a syndrome. It's defined by the signs and symptoms. HIV, having HIV is being HIV positive. Can you have HIV and not have AIDS?
Yes.
Of course, right? So many of the people who are on the medication don't have AIDS, but they're HIV positive. And in fact, there's a period of time between where you have HIV and you're HIV positive until you get AIDS. How do we define AIDS? Your T cell count and your opportunistic infections. Those are signs and symptoms. So we actually define AIDS by that, and that's why it's a syndrome. Make sense? Yeah, you have to have HIV to have that happen to you, but we define it by the signs and symptoms.
Does that mean the medicine stops working?
So yes, so if you don't take the medication for AIDS, then you will die, 100% fatality rate. And you'll die because of AIDS, right? Not from HIV necessarily, but from the opportunistic infections associated with AIDS. And so, yes, so if you don't take the medications or the medications aren't working or you're not taking them as prescribed, right? Then that's a risk. Now, the medications we have are very effective at keeping that at bay. So if you're taking them as prescribed, generally speaking, you can walk around with a undetectable viral load your entire life and live a perfectly normal life like you wouldn't even know it. But yeah.
So how does it turn into that?
Literally because HIV infects, like we were talking about with our ELISA thing, the HIV infects your captains, like your T cell captains that tell your rest of your immune system whether they can make antibodies or they can kill infected cells. So your captains tell your body that stuff, and HIV infects the captains and it kills all the captains. And then now you can't respond to any infections. So as HIV kills off the captains, then they can no longer signal the body to fight against things, and that turns into AIDS. Yeah, so that's why we go by the T cell count. Yes.
And you said like once they go on medication, though, they can reproduce their T cells.
Yep.
Correct. Okay.
Yes, if they go on medication, they can reproduce the T cells. Because
Do the
it's
captains keep on attacking the T cells as they're reproducing T cells?
so it's
How
not
does
that
that
the
work?
captains are attacking. Literally, HIV killed the captains.
Or, yeah.
Yes. So I had a lot of people leaving stuff around in the bathrooms and stuff
Okay,
like
I didn't flag.
that. Okay. Did you get it in the big room?
Yeah.
Yeah.
I wouldn't act.
Hopefully. Yeah. That's usually what we'll do is put it in the security. All right. Any other questions about that stuff? So HIV, we'll talk more about HIV when we get into chapter 21.
With the syndrome, does the cause ever matter?
Sometimes, well, we're not going to define the syndrome by the cause, but it's like in the example of AIDS, right? AIDS doesn't happen without HIV, but we're not saying, we're defining it, you have to have HIV and the T cell count and the opportunistic infection. So in a way it matters, right?
There are those objectives.
But yeah,
A little more like with the flu versus the common cold. I mean, because it seems like it's that complex. They got similar signs and symptoms, but you just kind of call it the syndrome of the cold until you definitively say that
Yeah.
you think it's flu.
yeah. And a lot of times at doctor's offices, they'll prescribe you stuff based on the signs and symptoms and not even test you for the cause. So based on how we are basically testing you, we might treat you for the syndrome as opposed to the actual cause. Now, if we think that it's a flu, we're going to test you for flu. We'll do a rapid test for flu, or we'll do a PCR test for flu.
Colds and flus, it's all virus related.
Yes.
So it's the same kind of, okay.
Yeah.
Thank you.
And it's sometimes hard to tell the difference, right? In some people, yeah, it just depends, yeah. All right, generally speaking, if you're an otherwise healthy person and you go to the doctor and they think you have the flu or a cold, they're gonna do the same thing, tell you to go home and fluids and rest, right? Treat your fever with some Tylenol. Yeah, right, so. Right,
Oh, man.
okay, so for PCOS, signs would not be ovulating, infrequent ovulation, high androgens, strings of pearls in the ovary. Exactly. So those would be signs, and symptoms would be like maybe pain, that you might be experiencing increased pain during your periods or no periods at all. Stuff like that can be associated with that. And it's a syndrome, right? So we have syndromes that aren't infectious related, like PCOS, and even Down syndrome. Down syndrome is a syndrome. It's defined by signs and symptoms associated with that disease. And it might be presentation of facial features like we're used to seeing in Down syndrome, or behaviors, but also we can look at signs like the fact that they have 3 of one of their chromosomes, which is trisomy 21. So chromosome 21, they have 3 of them instead of just 2 like the rest of us. So that's a sign. And so there's stuff like that we can define these things by these checklist types of things as opposed to the cause, the direct cause. All right, good questions, good engagement there. We're going to move on to chapter 14. So it's not popping up, but there it goes. Make sure we're signed in really quick. We're mostly just going to crank through this one. And I'll stop briefly for some explanation, but we've already called on everybody. So if you guys have questions, of course, stop me and ask questions, but otherwise we're going to mostly crank through it. 8098042. You guys are always really good at asking questions, but I'm never prepared for as many questions as you guys ask, just time-wise is what I mean. So I appreciate the questions though. Most random classes don't ask as many as you guys do. No, I mean, I'm not complaining. I think it's good. My average time that I have available for the things, I'm unprepared for it. All right. We shouldn't be going over time though with this one. And then the lab thing won't take the whole lab time. And we'll get done probably 20 minutes early. All right. Even if you're still signing in, no worries. We're going to go ahead and get started. And I'm going to sit down while I do this part probably. Move this out of the way so I can see people. All right, let's get going. Legs get tired. All right, who is Jon Snow? I'm not talking, right, I'm not talking about Game of Thrones, listen. Turns out he was not Ned Stark's son. Just saying. Anyways. All right, so he stopped a cholera outbreak using epidemiology. He basically saw that people in London were getting cholera. He mapped the infections. There was a water pump in the middle of that area, and he told people to stop drinking from it, and they didn't listen. So he took the handle off of it, and then lo and behold, people stopped getting cholera. So he was the father of epidemiology. Who is Florence Nightingale? Anybody remember that one? She's considered the mother of nursing. Mother of nursing. And she is the one during the Crimean War who noticed that the patients were getting basically dysentery, which is not transmitted from getting stabbed with bayonets like they were using in the Crimean War, or getting shot. It's associated with poop infections, fecal oral transmission. And so what was happening was the doctors and the other medical personnel, other nurses that were treating those patients were not washing their hands between patients. So she told them to start washing their hands between the patients and start practicing aseptic technique. She's the first one to practice aseptic technique, but because of her efforts in nursing with aseptic technique and treating the patients and stuff like that, she's considered the mother of nursing because of that. So Florence Nightingale and Jon Snow are old people for that chapter. We also had Robert Koch, which was the guy that basically identified how diseases were transmitted. I think it's in this quiz. Which term refers to the total number of existing cases with respect to the entire population? So how many people have COVID total right now? That's what this is talking about. Not how many people got COVID this month. Not how many people got COVID last week. How many people, the total number of existing cases, total is what I'm focusing on here. So if you ever see total, and I'm talking about the total of something, I'm talking about prevalence, okay? Morbidity rate and incidence are the same thing. And they both talk about how many cases in a time period. So in a specific time frame. So an example would be like the CDC and the World Health Organization often come out with like a monthly or a weekly, well, they call it the monthly morbidity report or something like that. And it's basically monthly. This month, how many COVID infections did we have this month? how many rabies infections this month, how many flu infections, and whatever. So that is looking at incidence, also known as morbidity. What's mortality talking about? Death, perfect. Morbidity is the disease, mortality is the death rate. Which type of outbreak occurs when pathogens come from a single source and all victims are exposed at the same time? This is one that I have a little bit of drawing to go along with it. I don't like that color. Beautiful. I'm very proud of you guys. So that's a point source. One source at one time. Common source. One source over a period of time. So in the case of those cholera outbreaks with John Snow's situation, those people weren't all exposed to that one water pump at that one time. They were continuously going to that water pump over a long period of time. That's a common source epidemic. Point source. If I have COVID and I come in here and cough and 5 of you end up with COVID, that's a point source. Okay? Point source outbreak. And the last one is a propagated. Means it's maintained in the human population. So COVID is a propagated epidemic now. We're maintaining it in the human population. And it's evolving within the human population in the wild, right? We're not getting reintroduced to it. New source anyways. Does that make sense? Leave that up. All right, true or false? A pandemic is the spread of an epidemic across continents. Oh, come on. I clicked on you like 3 times. So, okay, we have endemic. What's endemic? Does anybody know? So endemic will be that normal level that's found in that area. Level in a region. Let's see. Yes, regional. So how it's normally found in that region. Sporadic is just a random outbreak. It's usually very, I want to say, finite. So if a dog bites a person, if that dog had rabies and bites a person, that person gets rabies, that's a sporadic incident, right? If we get Ebola, if somebody travels to a country where Ebola is found and then brings Ebola back here and gets a couple healthcare workers infected with Ebola, but it stops there, that's sporadic. If they keep getting it to other people, that would be an epidemic. Okay? So it continues like that. Epidemic means that it's spreading beyond what's expected. And then pandemic, like we said here, easy enough, across continents. An epidemic across multiple continents. All right, we good? Again, chapter 14, pretty heavy on the flashcard stuff. All right. I don't say that a lot about my class, but this stuff is definitely that. All right, which term refers to a disease that exhibits at a steady expected frequency over a long time in a particular place? I asked you this question and it is written up on here. You can see it. Expected level in the particular place. One of these matches that. All right, that's endemic. Good job, everybody. If it exceeds that, so when COVID first started here, that was an epidemic because we had zero COVID was at the endemic level before. Endemic level was zero. Epidemic was beyond zero. Makes sense? And so if you have like 5 or 6 cases of the flu periodically, but now suddenly we're getting hundreds or thousands of cases, that went from the endemic level to the epidemic level. Yeah, good. Yes.
Something I thought was with an epidemic, the time that the speed
Mhm.
and the numbers is by different diseases.
Yes, it depends on the disease and the area and the population. Yeah, it's just a more complicated way of looking at whether it's an epidemic or endemic. And it just depends on the disease and the numbers in that population, all sorts of stuff involved in that. So this one, we're getting into sensitivity, and which you guys got this one. So I'm actually pretty proud of you because other classes were having difficulty with it. What do I want to erase here? I think I want to erase something, but I don't know. Let's just put it out to the side of it. All right, when we're doing diagnostic testing, and we're going to see this again in Unit 3, we can basically measure our test's effectiveness. We'll say even effectiveness of diagnostic testing. We're looking at the specificity and the sensitivity. How specific a test is or how sensitive a test is. One of my students happened to notice a trend here. N and P. This will make sense in a moment, okay? So we're going to focus on those in a second. But if we're looking at the sensitivity of something, we are looking at the ability of that test to identify all positives, even if they're in small number. In specificity, we're looking at the test's ability to identify true positives. So what's the difference between these two? In sensitivity, we want to make sure that if that person is positive, we're calling them positive. For example, if you take a home COVID test, you're feeling sick, you've got all of the symptoms and signs of COVID, and you take a home COVID test and it is negative. Does that mean you're negative for COVID? All of us have been told, no, go get a PCR test because the PCR test is more sensitive because the PCR test can identify even one little tiny virus. Your home test can't. The PCR test can identify even the smallest amounts. Makes sense? So that's sensitivity. Even one virus. The more sensitive you are, the more likely you'll catch all of the positives. So if I were to say that a home COVID test recognizes 90% of positive individuals, like let's say you have 100 individuals in a room, they all have COVID. The home COVID test will identify 90 of those 100 as having COVID, and 10 of them, they have it, but the home test didn't pop positive, it was negative. That's a measure of sensitivity. Okay, so that's one aspect that we can look at with our test. We want a test to be more sensitive to avoid calling something negative when it's not. If you call something negative when it's actually a positive, that's called a false negative. Negative, N. Sensitivity, N. So sensitivity is a measure, basically trait of our test to avoid false negatives. Avoid false negatives. Sensitivity, the higher the sensitivity, the less false negatives. Higher sensitivity, less false negatives. Okay. The other one, and they'll make sense how they're different, I promise. Specificity. You want to identify true positives. How many tests are there out there that could positive when you're not actually positive. So we know that there's some drug tests out there that will say that you're positive for a drug, but you're not actually taking that drug. You're taking something else that made it positive. That's a specificity issue. That makes sense? So specificity, identifying something as truly positive when it's actually positive for that thing, not something else. So we want to avoid saying it's positive when it's actually negative. That situation is known as a false positive. Higher specificity, lower false positive rate. Specificity, P, pos. Okay, so that's how I remember them, but you have to have the context there. So the higher the specificity, the more specific it is for that specific positive. And we're not going to have false positives because of that. Sensitivity, the more sensitive it is, the more it'll pick up on all of the positives and not have false negatives. Do not confuse yourself into thinking that you have to have one or the other. That's not how it works. Tests should be the maximum at both of these. These are different aspects of testing. You want both of these traits. All right, we following okay?
So the distance like 50-50.
Yeah, it's not very high. I mean, it's not super sensitive, right? So, and we kind of know that about it. It's not super sensitive. In fact, I have repeatedly tested negative on home COVID tests when I will be very, very sick, 104-degree fever even. And then I end up getting a PCR test and it would be negative also. And then at the end, when I would take the test at the very, very end of my illness, I get another PCR test done. That's what happened with COVID, and it was positive at the end. But what happened was COVID infects more than just your sinus tract, and we're only testing the sinus tract. If I didn't have COVID in my sinuses, but in other parts of my body, then I'm going to pop negative on even a PCR test. So even the PCR test isn't 100% sensitivity, very high, but it's not 100, right? So, make sense? I don't know why that is, but just how my body is infected with COVID, I guess. But yeah, I've had that happen twice. All right, moving on. I think we're out of the there's one more thing that's a little bit tricky. Koch's postulates, what were they used for? I'm gonna delete this stuff written on the board so you can see our stuff better. Koch's postulates. So Koch's postulates were designed to determine the causative agent, also known as the etiological agent, the thing that's causing a disease. So what he did was he was able to take people had this disease. We basically took a swab out of the people, tried to isolate that microbe and put it into a mouse. Did the mouse have the same disease? If it did, mice or anything, it didn't have to be mice, but in his example, it was a mouse, okay? If the mouse came up with the same disease, that was the thing that caused that disease. And it repeated that, he could repeat it that way. Seems really basic and simple, but like back in the day, whenever they're first coming out with germ theory generally, this was like new stuff to them. So he actually discovered the cause of anthrax this way. So that's Robert Koch and Koch's postulates. A set of steps to determine the causative agent, also known as the etiological agent. Question 8, 2 factors are collected at a single time with no reference to which might have occurred first. This is a type of study in epidemiology. Epidemiological study. Fine, blue is fine. All right, there's 3 major epidemiological studies. We have the cross-sectional. We're going to look at traits in a group at a specific time, at a single time, I should say. So if I have, we have an outbreak going on, and I just take a group of people nondescriptly, and we say, do you have signs and symptoms? Which, like, do you have cough? Do you have fever? Do you have this? Do you test positive on a test? Do you test positive on a PCR and stuff like that? But we're not saying which happened first or how or when, or looking at the progression of the disease. We're just taking a group of random people and saying, how many of them have signs and symptoms? How many of them test positive on this and whatever? That's cross-sectional, okay? The next one is case study. Case control, excuse me, case control. It's a case control study. A case control study is what it sounds like. Don't get too confused by it. We take cases, people that have the disease, and compare it to people that are the control group, people that don't have the disease. Compare those with the disease to those that don't, to the healthy people. Okay. The last one is the cohort study. In the cohort, we're going to look at changes over time. Usually with a risk group and a non-risk group. And a good example of a cohort study is we have a group of smokers and a group of non-smokers and track them over time. Which group has more increased chance for lung cancer? So if we track non-smokers and smokers over 10 years, how many of the non-smokers got lung cancer versus how many of the smokers got lung cancer? You know, take a group of women that don't have breast cancer. And we have women that we do genetic testing on, women that have this genetic marker versus women that don't have that genetic marker. Which group tends to get breast cancer over time? Usually cohort studies are typically done with those longer timeframes in mind for like longer time for appearance of the disease. A good one that might be good for infectious disease might be looking at something like mad cow disease. Take people that visited Europe in the 90s and for people that didn't, and how many of them ended up with mad cow disease. The people version, which is CJD. Any questions about the studies?
Risk, non-risk.
Yes, the cohort group would usually be looking at a risk group versus a non-risk group. Or risk versus non-risk groups. All right. Last question. I think it's going to be with are not. Oh, I gave the answer away. What term refers to how many susceptible people on average one person will spread the infection to? Are not. Okay, are not, R sub-zero, also known as R not. This is infectiousness or contagiousness. How many people, if you have COVID, are you likely to infect? We believe COVID's R not is somewhere around 5. If you have COVID, you're likely to infect 5 other people when you have it in the course of your infection on average. One of the highest, most infectious or contagious diseases that we've ever seen in mankind is the measles. So if you have measles, the number of people that you're likely to infect is close. It's like 90% of the people that you're going to come into contact with. I don't know about the exact R not, but yes. 15. Okay, yeah, that's good to know. Yeah, but it's one of the highest R naughts that we have out there. So this deals with contagiousness of it. Another number that the book talked about was CFR, which is case fatality rate. And I want to be very clear about case fatality rate. Case fatality rate is for number of people that will die if untreated. All right, there are a few diseases that have 100% CFR. One of them we've already talked about, which was mad cow and other prion diseases, 100% case fatality rate. Another one that we've talked about was rabies, 100% case fatality rate. And then the last one that is probably the most famous is HIV. If untreated, 100% fatality rate. Not many diseases will get up to 100%, but these ones are 100%. Yeah? Okay, so that's case fatality rate. Another topic that this chapter talked about was herd immunity. Do we understand about herd immunity? Herd immunity is the number of people that have to be vaccinated to protect the people that aren't vaccinated. For measles, that's around 96% of the population needs to be vaccinated to protect the people that can't be vaccinated. What that means is that the disease doesn't spread enough in the population for it to affect the people that aren't vaccinated. So each disease, that depends on the R naught. That depends on how contagious a disease is, how many people you have to have vaccinated. So if we don't get to 96% vaccination, we can't protect the people that aren't vaccinated. That's herd immunity. Right now in the United States, we do not have herd immunity for measles anymore. We used to. We eliminated measles from the United States. We had it eliminated, and then it's been brought back in by other countries that were not vaccinated and did not eliminate measles, because now we're, yeah. And so we have plenty of people. We've had people in Texas, Oklahoma, and Kansas, Arkansas, Missouri, all over in the area, people getting measles now again. And who's getting the measles? The kids, because the kids are the ones that aren't vaccinated, because all of the anti-vaxxers that are fighting for no vaccination, they're adults that were vaccinated. Because again, when I was a kid, you had to be vaccinated in order to go to school. It was not allowed that you would be allowed to go to school if you were not vaccinated. So this is a different mindset now that we have going on with the anti-vaxxers. Again, they're all adults who have been vaccinated that are saying this stuff, living high and mighty on their, disease-free pillars, talking about how we shouldn't get vaccinated. Meanwhile, their kids are going to end up in the hospital with, encephalitis and meningitis caused by measles. It's wild, but anyways, be educated. That's all I'm saying. All right, so that's it. We're gonna say we have, here's our little podium. That was the last question, wasn't it? Oh, there's something more. Case fatality rate. We already covered it though. The likelihood. I mean, I wrote it and underlined it, so hopefully, hopefully we see it up there. All right, so it's going to be the likelihood that you'll die if you're untreated. And so that's the key there. If you're treated for HIV, you can live forever, just as long a happy life as anybody else. But if you're untreated, 100% fatality. So here's our little podium. Our activity for the day. I don't think there's anything we didn't cover. But I'm not going to go over it in detail. If you guys do want to visit it, then the questions and the stuff that are associated with this chapter are available on our lecture activity assignment in your modules. But it basically asks us to explain why this is a cross-sectional study, because they're taking a group of people and then just looking at factors at that moment in time. It uses PCR to look for viral load, but what other things besides how much virus you have might affect your severity of your symptoms? So it could be your immune status, your age, whether you're pregnant or not, whether you have comorbidities, like if you have kidney disease, or if you already had a lung disease, or if you have cancer or something like that. Those are comorbidities. This uses cross-sectional data as a predictor of epidemic trajectory. So trying to predict how the epidemic is going to go based on cross-sectional data. But why might that not be ideal? Again, we're not looking at comorbidities. We're not looking at maybe where these people live. Are they living in interurban areas, or are they living in upper class areas? Are they getting the same health treatments and things like that? Those are all factors that might be getting left out in that consideration, as well as, what type of setting, just generally, are they in a first world or a third world country? Stuff like that can help predict the trajectory as well. Knowing what we know and discussed about the vaccine and how it trains our body, what would you expect to see a cross-sectional study look like now with the vaccine? Well, I would expect that if you're doing a cross-sectional study to look at signs, symptoms, and PCR results, you might still have high levels of PCR positives, but their signs and symptoms would be less severe now after we've had introduction of the vaccine. We're still getting the disease, but it's a less severe presentation, right? And the last one, summarize what a case control study might look like, looking at people who don't have COVID during the outbreak, don't have the signs and symptoms, versus looking at people that do have the signs and symptoms, and then looking at factors of those differences between those two people, right? All right, any questions about any of the epidemiology stuff? All right, take a break, and we will do our lab stuff here in just a couple minutes. Lab stuff is going to be done early. Clear the screen.
Yeah, great. Sitting there for that part.
Cool.
Yes.
Yeah, what's up?
Specificity and sensitivity.
Yeah.
I just.
Okay.
Sorry, yeah, I don't think so.
People get confused about them a lot. So I try to go over it a little bit, but I also don't want to like overkill it. The more sensitive you are, the more likely you're going to be affected by a small number of things. The more specific you are, the more likely you'll be affected by that specific thing as opposed to things that look like it.
So it really is just.
Mm-hmm. Yeah, I think it's just the words, but a lot of people, because they're similar words, they're similar words, right? I mean,
But the specific means it's specific to that thing.
Mhm.
So sensitive means it's more sensitive to that.
mm-hmm. Yes.
Can you clarify devour before 12?
Yeah, that should be fine. Yeah,
And then I'm still.
that's fine. Yeah, you'll be good. The what?
Like these. There's some
Yes.
of them I couldn't, like, I tried looking up.
I don't know why I started this.
Stuff about
Sorry.
But I couldn't,
That's whatever.
I looked it up, I couldn't like get like info about it beyond like it's transmitted by.
That's fine. That's all you need for it. It's transmitted by uncooked pork, right? Specifically. So yes, we'll go over some of that stuff today too. Yes. And I'll tell you guys what I expect you to know out of it. I don't know. I started this on accident. That was my fault. I'm gonna restart it. Everybody gets 0.
That we're gonna put, you sent out.
Yeah.
German?
Yes. There we go. Try again. Here we go. Go put a note on the upstairs phone and stop on my this real quick and I'll be right back down. People are still running up to that, whatever.